to help us sort of sort questions, but if you just want to put in your question, that's totally great too. So today moderating for us is Dr. Erica Schillinger, and she's a clinical professor in medicine in primary care and population health, also the Vice Chief for Education in the Division of Primary Care and Population Health. Her academic passion is patient-engaged medical education, including doctor-patient communication, professionalism, physical examination, and clinical reasoning. Dr. Schillinger is also an educator for care, in which role she mentors approximately 30 medical students each year and teaches them clinical skills in the practice of medicine course and the Doctoring with Care series. So I'm going to turn it over to Erica to get us started.
Thank you, Christine. Can you give me a thumbs up if you can hear me? Excellent. So I want to provide a little bit more context and just say that this is the first in a series of 5 seminars in which over the course of the series, we will hear perspectives from clinicians, faculty, trainees, patients, and caregivers about practices and lessons learned from telehealth that many of us, all of us, have been learning exponentially over the last couple of months. With the housekeeping out of the way, thank you, Christine, I want to say it's really an honor to introduce such an exciting group of speakers. We have a star-studded panel. And what I plan to do is introduce all 5 speakers at the beginning, and then we'll run the presentations in series. And as Christine mentioned, please submit your questions. We will be feverishly collating questions on the back end so that we have time at the end for you to have your questions answered. So without further ado, it's an honor to introduce our first speaker will be Gil Chu, Professor of Medicine and Oncology and beloved educator. He's going to open us off with patient factors. And then Donna Zollman will follow. She's an assistant professor in primary care and population health and an investigator at the Center for Innovation to Implementation. She will discuss her recent work with Telepresence 5 and humanism in telemedicine. Patty Garcia, Ambulatory Specialties Medical Informatics Director, will discuss telehealth resources, including physical exam and billing. Following her, Rika Bajra, who's the Associate Director of the Core Clerkship in Family Medicine, will talk about integrating learners through the telemedicine curriculum in family medicine. And then closing us up and bringing us home will be Sumit Shah, Medical Director of Digital Health Solutions in Oncology. He will be talking about troubleshooting technology and team members. We are going to be moving quite quickly from topic to topic. Each speaker has 7 minutes, and I will be showing a 2-minute and a 1-minute indicator and then end for our speakers. So please, for the speakers, if you can keep my little thumbnail up on your screen so you can see my indications, this means you're done. And yes, so why don't we get started? Please, Gil Chu.
Okay, I'm going to talk about patient issues in telehealth, and we're going to do 3 topics: technology, COVID-19, which is why we're doing this in the first place, and language. And what you'll see is that telehealth offers some advantages and some disadvantages. I'm going to do it from the point of view of patient stories as illustration, and many of the topics will come up later from the other panelists, so I won't spend a lot of time in each one. Next slide, please. So technology fails for some patients. Some don't know how. I had a patient, Pam, who had metastatic colorectal cancer. She actually knew how, but she was too sick. And her husband, Dan, sells fish and doesn't have an advanced education. And he ended up having to take care of everything. So he was unable to use MyHealth. He doesn't have a smartphone. So the normal telehealth wasn't available. simply wasn't available. So we just talk by phone. Second example is some people refuse. Nina, who I've known for 14 years with metastatic carcinoid, came from Russia, and I'm not disclosing anything really because she's really 90 years old, but the immigration officers got her age wrong. And so she's listed under a different age in EPIC. But she says she's too old to learn MyHealth, even though I'm sure she could. And she basically takes a bus from Turlock every 4 weeks just to get an octreotide injection, primarily because she just wants a hug from me and to share. And a telephone conversation isn't really what she needs. Finally, and some people just simply prefer the phone. A patient, Anne, with a GI stromal tumor on imatinib treatment, lives in Aptos. When she comes to clinic, she's always well-dressed and looks wonderful. But she likes the remote visits, likes not having to drive to clinic, but absolutely refuses the video connection because she doesn't have to drive in. She'd just prefer not getting herself dressed up and looking good. Next slide. So COVID-19 fears overwhelm some patients. I've even had some people avoid treatment. Jose, Hispanic male with metastatic pancreatic cancer and diabetes, was a self-employed person repairing trucks. And he likes telehealth. He's actually been able to master the technology. And he likes it because it helps him avoid the clinic. He's deathly afraid of the coronavirus. And so afraid, he wanted to avoid going to the infusion center. So he skipped his scheduled infusions and his markers started going up. In terms of self-care, he stopped taking his fasting blood sugar because he figured he'd either die of cancer or COVID. And a random blood sugar that we got finally was 350. And so we had to talk by video about taking care of himself. Here's where the video actually helped because I could tell he'd gained weight by just seeing his face. And that's part of the physical exam. And then finally, the issue of hospice. Pam, who I talked about, whose husband sells fish, refused hospice for over 6 months, even though there was nothing more we could do. The pandemic started and she was fine with phone visits. And finally, Dan accepted hospice despite Pam's insistence against it because they needed to avoid trips to the Stanford ER and further exposure. So next slide, please. The language barriers often loom large. I think about 40% of my patient visits need an interpreter. Depending on your clinic, different people have different patient populations. But Sumit will discuss things with the interpreter. But I wanted to tell you this story about a patient Wei in his 90s with severe dementia, unresected metastatic colorectal cancer that was continuing to bleed, requiring transfusions every 3 weeks. But Wei enjoys the interpreter because he enjoys seeing the interpreters in clinic. And the first time we had a video visit, the interpreter didn't show her face. And when I asked the interpreter to start her video portion, the patient lit up, and that really helped. Resources and education. Wei and his wife need their daughter Julia to manage the video visit, and they're completely dependent on her. They'd be lost without it. Jose, the truck repair guy, has poor internet service, so every now and then things just wink out. In terms of culture, going back to Wei in his 90s and daughter Julia initially refused hospice. It's obvious this patient should be on hospice. And didn't want strangers in the house. That's a cultural thing. Wanted blood transfusions to continue so Wei could pass away only after the coronavirus pandemic came to an end and they could be together. Next slide, please. So to sum up, like coronavirus, telehealth actually amplifies socioeconomic disparity. I think that's one of the underlying themes of some of these stories, and certainly something that I've learned. Things have worked out well in some respects, but been very difficult for patients without resources or without technologically savvy family members. It would have been impossible otherwise. So thank you.
Can you all hear me? Yes. Okay, great. Hi, my name is Donna Zolman. I'm delighted to be part of this group today discussing telemedicine. I'm going to be talking about strategies that clinicians can use to foster meaningful connections with patients during video visits. This work, next slide. This work is part of a larger project called Presence 5, where our objective has been to develop a simple, scalable, evidence-based intervention that fosters physician humanism and patient connection. And for this project, we did a large systematic literature review. We interviewed physicians and patients and observed clinician-patient encounters in 3 diverse settings, including Stanford internal medicine and family medicine clinics. We interviewed people from outside the field of medicine to learn about their analogous experiences with intense interpersonal interactions. And then we brought together a group of experts, including physicians and researchers, patient and caregiver advocates, to synthesize what we've learned and come up with some key practices. And what came out of this work was the 5 domains that you see on the right, the 5 practices. We published this work in January, and then of course, COVID came around, and all of this had been done in the context of in-person interactions. And so with the rapid change and shift of care from in-person to virtual modalities, our team then kind of went back into the literature and started talking to clinicians again to find out how we could adapt these practices to virtual visits. So that's what I want to share with you today, these 5 practices and some specific recommendations for how we can connect with patients in a meaningful way during telemedicine encounters. Next slide. So the first practice is to prepare with intention. This is all about familiarizing yourself with the patient you're about to meet and creating a ritual to focus your attention before a visit. And in the in-person setting, we have a natural transition between visits, so it might make sense to put your hand on the doorknob before you enter a patient's room and just take a deep breath, or while washing hands, create sort of a ritual for yourself where you focus your attention before you start talking to the patient. We don't have that natural transition in telemedicine, and so it can be helpful to create a ritual like standing up between visits, taking a deep breath, stretching, having a sip of water, just to clear your mind and really focus your attention on the next patient, because these back-to-back visits, and anyone who's been doing back-to-back Zoom calls knows just how fatiguing it can be. A second part of this is to really familiarize yourself with the person you're going to meet, and that's involves a brief chart review, which we typically do, but we're often very focused on the medical issues that the patient has. And here we want to also really pay a lot of attention to the social history, what are the life circumstances, who does the person live with, their occupations, some information so that when we sit down face-to-face with the patient, we really have a sense of who they are. And then the last piece of this is to minimize distractions before starting the visit, so put away the cell phone, turn off alerts, again, so that you can be fully focused on the visit. Next slide. The second practice is to listen intently and completely, and this is really all about nonverbal communication and positioning yourself to hear the patient's story. Again, in the in-person setting, there's a lot of evidence around sitting versus standing, eye contact. There's less evidence for us with telemedicine, but a lot of the same principles can be applied. So sit up, lean forward, stay in the frame of the camera, and then look directly into the camera to maintain eye contact. And here it can be helpful to position the patient's image right under your camera so that when you're looking at the patient, it looks to the patient as if you're making eye contact with them. Because the resolution might not be very good for some of our visits, we need to be more expressive than usual and nod and kind of use body language to really help communicate that we're listening. And then just as it's critical in in-person settings not to interrupt the patient, in the virtual visit, we need to be especially attuned to lag times and really pause before responding to avoid interrupting patients. Next slide. The third practice is to agree on what matters most. And this is something that we're all very familiar with, making a shared agenda with the patient, and I think it translates very well from the in-person setting to the telemedicine visit. But patients may not be familiar with telemedicine, especially early in the pandemic. For many patients, it was their first time having a visit like that. So they don't know what to expect necessarily, and it can be helpful to kind of describe the structure and come up with an agenda together so that they understand that their priorities and goals will be discussed as part of the visit. There's evidence to show that patients tend to speak up less during virtual visits compared to in-person visits, so it's especially important to use open-ended questions and utilize teachback to assess understanding. And then, again, because telemedicine is new for many patients, it's helpful to reassure them that you're there for them despite the virtual nature of the interaction, and discuss with them what elements and what pieces of the health system are still open to them during this time. Next slide. The fourth practice is to connect with the patient's story. And here we really have an opportunity with video visits. I think there's a lot of discussion about the potential challenges and adverse consequences of telemedicine, but in some ways, the telemedicine visits can be an invitation into the patient's home and really give us a glimpse of their living environment in a way that we haven't had previously. And so part of that can be, commenting on personal items that you see, their pets, their photos, their furnishings, making a connection with them around some shared interest. You can invite individuals who are present with them to introduce themselves and learn about their social support. And then in some situations, it might be appropriate to learn about the patient's home environment and safety, look in their fridge with them, look at their medications together, but always being sensitive to privacy issues and being aware that some of these questions are sensitive. And so one strategy is to use a yes/no question at the start of these conversations to make sure that the patient feels comfortable discussing these topics at that time. Next slide. And then the fifth practice is to explore emotional cues. One of the experts we work with for Presence 5 talked about how the face can be a roadmap of emotion, and I really love that. I think we can learn so much from tuning into a patient's emotions. And again, over video can sometimes be a little bit harder to see the nuances of emotions on a patient's face, so we might need to rely more on their body language and their tone and volume of speech. And in some situations, asking the patients how they're feeling about their health concerns and stressors so that we make sure to elicit those emotions, and then of course name and validate the observed emotions to make sure we get it right. And just as it can be hard for us to read our patients' emotions, our patients might not be able to read our reactions as easily as they would in person. So again, being expressive with facial cues, saying out loud how you're feeling. One clinician talks about, putting a hand to her heart as a way of expressing, how they're reacting to what the patient's saying. Those can be helpful cues. Next slide. I just wanted to wrap up by thanking the Presence 5 team, including Abraham Verghese, who's my co-PI for this project, all the team members and students and interns who contributed to this. If people are interested in learning more, at the link below, we have a one-page kind of poster that people can print out and share with trainees. And then there's also a link to a brief CME if people are interested in learning more. Thank you.
Okay. So thank you guys for your attention and inviting me to be part of this panel. My name is Patty Garcia. I'm, in addition to one of the medical informatics directors for the ambulatory specialties, I'm one of the gastroenterologists here. And I'd like to spend a few minutes today talking about the resources available to us as we help navigate this rapidly developing world of telehealth with a specific focus to the virtual physical exam and billing. Next slide. So hopefully many of you recognize this. This is the SHC Connect webpage where most of us navigate to get to a whole host of sites, including Epic. And from this website, there are 3 links to the new AskSHC website where you can find answers to many of your technology and digital questions. So in the bottom right, there's the quick access links, which are always there. And you can see I've highlighted the AskSHC link. And then if you connect the drop-down arrow next to Connect To in the upper right, you'll see also 2 links to AskSHC. Next slide. So when you go to the AskSHC website, this is what you'll see. So Epic Central, ServiceNow, the TDS service catalog, all of those things have been bundled into this new AskSHC website. And this is where you can search for information, view articles, ask for help, navigate to subportals like service requests for your computer, all in one place. And as you can see, the search bar is modeled on a Google style experience where you can type in any keyword or question. So it says search for anything and get a list of relevant information. So in this case, the keyword I would recommend is video visit. Next slide. So if you type video visit, you will get a whole host of articles on troubleshooting, the app, and the ones I'm going to highlight here are related to the physical exam and billing. So this is the video visit physical exam tips article. As you can see here, there's a little video link to a wonderful 15-minute video that was created by Drs. Artani and Srinivasan in the Division of Primary Care, which demonstrates how to perform a provider-directed patient self-exam. So the simulations they run through in this 15-minute video are for upper respiratory infection, low back pain, and shoulder pain, but the techniques and the tips apply much more broadly, and it's well worth a 15-minute watch. The article also contains tips on how to perform a virtual physical exam, some of which I'm showing here on the screen for your reference, as well as a sample comprehensive physical exam that you can use for documentation. So I'm not going to go through each of these, but my goal is to point you to these resources where you can learn more. Next slide. So this is another article, a second key article, which is the video visit documentation and billing article. It's where the latest changes in documentation and billing policies are being collected. In fact, it's so, we're updating it so frequently that even this slide is out to date. We just updated it this week with new changes that have come along. So it's a great place to find things since everything is changing so rapidly with CMS. In terms of the physical exam, what I've highlighted here are references in this article to system dot phrases that you can use when you're seeing patients via video visit. So .vidpe will bring up a smart list and you can select a comprehensive exam, a limited exam, a post-op exam, or an audio-only phone exam. And these are great ways to help you start thinking about how you want to document your virtual exam. It kind of lets you know what's possible and you can adjust it to your own personal practice. I've also highlighted the .vid consent smart phrase, which contains the attestation that's required for compliance when we do these video visits. Next slide. So this is another article. It's a recent article that we added that shows the difference in terms of billing and documentation between in-person visits, video visits, phone visits, and phone calls. And so it's well worth a look because there are some variabilities and this is also ever changing. I've also outlined in yellow a great feature of these AskSHC articles, which is that they show you related articles to the one that you're viewing. So in this case, let's say you look at this chart and you're interested in learning more about telephone visits and how do you schedule a telephone visit, or how do you create a telephone visit on the fly if it's unscheduled. You can see that on the right, you'll say, oh, look, there's another article about that, and you can click on there to learn more. Next slide. So the main documentation and billing article that I referenced also contains information about the actual telehealth and virtual codes, similar to those shown here. There are also links to the Stanford Compliance Intranet, which has more extensive documentation about these codes as well. One thing I'll just mention, we could spend an entire lecture on billing and coding, but there's a lot more out there than just telephone visits and video visits. There are codes for virtual check-ins, for reviewing patient-submitted images, for patient portal communications, for e-consults. So it's a whole new world of telemedicine that I think we're all just starting to learn about, and these are great resources for that. Next slide. So in the last few minutes, I just want to highlight some non-Stanford resources. So there's a national consortium of telehealth resource centers. There are 12 regional and 2 national telehealth resource centers that were funded by the Department of Health and Human Services to help develop telehealth programs, especially for rural and underserved communities. So the National Telehealth Policy Resource Center, which I'm showing here, provides policy assistance to these regional centers, as well as to state and federal policymakers, the public, health systems, and us. The 2 sites I'm showing here, one is a page that's dedicated to summarizing the CMS coverage policy changes, and the other is a page dedicated to summarizing state actions, so like changes in licensure requirements. So it's a great resource with up-to-date information and has a lot of the questions that you probably are asking with all the changes that are going on. Next slide. And then the last resource I'd like to talk about is the AMA Telehealth Playbook. So the AMA has started a series of playbooks aimed at identifying key steps and best practices for implementing telehealth. So their first playbook focused on remote patient monitoring, and this is their second playbook, which is all about telemedicine. So it's 128 pages, so a little light reading, but it tries to walk you through how to integrate telemedicine into your practice. A good part of the playbook is really geared to practices and health systems who are just starting the process. So it talks about selecting a vendor and contracting, But there's a large section on designing the telehealth workflow, partnering with patients, telehealth etiquette, how do you coordinate a virtual team, coding and payment. So I think it can be really helpful, even at places like Stanford that are already at the forefront of digital health technology. There's also a quick guide, which I've shown here. So if you don't have time for the full playbook, there's a quick guide with highlights on implementation, policy, and coding. So with that, I'll stop. Thank you for your time.
Hi, my name is Rika Bajra. I'm a family physician and also the Associate Director of the Family Medicine Clerkship. I came into telemedicine when I started doing a standardized patient exercise in our clerkship, and I had received a generous grant from the TMA. And essentially, over the last couple of years, as I've been watching students in their video visits and this exercise, what's been really exciting for me is that it's a space where we're so new to it that we're all learners. And so looking at the participants here, if, whether you're a medical student or an attending, I'm hoping that I can provide some ideas in terms of how you can teach your teacher and learn from your learner. Next slide. So in our family medicine clerkship, a couple of months ago, all learners were taken out of the clinic setting due to COVID-19. So Tracy and I created a virtual ambulatory clerkship. And it had three components. One was didactics through Zoom. The second was patient care. And the last was the OSCE that I had mentioned, the standardized patient exam, which we assessed for clinical and communication skills at the end. From the telemedicine perspective, we did the didactic on best practices in communication and physical exam. And for patient care, our students accompanied their preceptors in family medicine. We used a platform that used Epic and Zoom in parallel. And I think Dr. Shah will mention that a bit in his slides, but essentially it was primarily shadowing for this particular pilot, but we hope to integrate an option where they have more autonomy, which I'll show in the next slide. So next slide. So this is a model here of what we envision we would implement once Epic moves to a multi-party platform. It would be a flow where the student would log in, greet the patient, help them through any kind of telehealth issues in terms of problem-solving technology, and practice all of the things that Donna mentioned, establish rapport, and find out what the goals of care are. The student would take a history, and then in step 2, call the attending, join the visit with the attending, preferably summarize a patient history in front of the patient. I think that helps with the patient feeling reassured that their story was heard, and also leading the patient through a provider-directed patient exam, which Patty alluded to earlier. Lastly, after they come up with an assessment, discussing this with the patient and following up with clear follow-up guidelines and next steps in terms of next visit. So next slide, please. I have a few tips in terms of how to optimize learning in this setting. I have a separate slide for pre-rounding, but specifically it helps prime the learner. And as Donna mentioned earlier, really prepare for the visit with intention, getting to know the patients a bit more than their clinical conditions, maybe their social history, and be able to engage in a more effective way. As we talked about, the physical exam and relationship building is very unique in a video visit. So being able to talk and explore about how this can be done effectively are good teaching points. I think that verbalizing exam findings, I noticed that you're able to speak without any shortness of breath or finish your, I noticed that there's no redness or swelling, are good points in terms of being able to engage your patient in terms of what you're finding and help you make an assessment in terms of in terms of the diagnosis. I also think that providing clear instructions for a provider-directed patient self-exam is a wonderful opportunity for learning. I have found that many of my learners are learning or seeing presentations of clinical conditions for the first time on video visit. So I think it's valuable to review thought processes in which you explain how your medical decision-making and recommendations for follow-up might be different because of the limitations in a video visit. Next slide, please. So this is one of my favorite slides. It's created by Elaine Tran. She was a medical student in our last clerkship, and Elaine was a rock star in video visits. She took amazing notes. She researched clinical topics on the fly, and she made really effective patient education materials. So I had asked her what she did to prepare, and here are her pearls. So essentially, she looks at specific things she might adapt for her preceptor, and that might look like what their notes or for how their notes are formatted. You might look at their relationship with patients, and if it's a new patient, she would do some early chart review in terms of prior records through Care Everywhere. And next, she looked at the chart for some high yield items in terms of prior visits, outstanding labs, specialty referrals, and even looked at things like preventative care, what immunizations they may need and what screenings they would do for. Next slide. Lastly, she really anticipated the virtual interactions. So that included finding out names of family members and caregivers, aspects of their social history. She set up her workspace so that she had an effective background and was able to maintain good eye contact, and really had some resources nearby. So if she needed to bail and use another format for the video visit, then she would have a phone or a tablet nearby. So I think these tips would make anybody quite effective, and I love that it came from one of our students. Next slide. Lastly, this is a standardized patient exam that we implemented, and the main goals were to review chronic care management as well as patient care communication. We had been running this for about 2 years and the Interactive Learning Center in person or on site. And last month we ran it through Zoom, and it worked out really nicely. We had each student with a standardized patient, and Tracy and I watched as a hidden faculty observer. We used a checklist to observe their communication, and then the students had one-to-one feedback with the standardized patient as well as our group. And so this was our 5 students here who did our clerkship and needed our clerkship to graduate, and they were our first pilots in this telemedicine curriculum. That's it, thank you.
Terrific, thank you so much. Thank you all for having me today. My name is Samit Shah. I'm in the Division of Oncology, and I do lead many of our digital health efforts within the division. I think we've seen how powerful a tool digital health and telemedicine can be in terms of improving access to patients and potentially bringing down geographic barriers, which is especially important for those of us at Stanford who have patients traveling 4 or 5 hours away just to come see us, with the caveats that Gail mentioned earlier, but this can be an incredibly powerful tool. That said, it can also be incredibly frustrating when technology does not work well, and I think we've all been in those experiences. So I wanted to talk today about a few commonly presented problems that we have in telemedicine, specifically with our own Epic interface that we're using at Stanford. And then some common troubleshooting tips that I would advise for all of you. So go to the next slide. The first one is audio difficulties, and this is very, very common to see. This very quickly devolves in this very awkward game of charades, as you've noticed with many of your patients. We're trying to communicate that you're going to call them back, or that they can hang up, or try logging in again. And it can be very difficult and also time consuming. And you waste a lot of time if you only have like a 15 to 20-minute encounter with the patient. So in addition to all the normal IT solutions, such as making sure that you're not muted, that your patient is not muted, even logging off and logging back in. On the next slide, I'll remind you that low-tech solutions are also very important to recognize, and they can also work just as well. So I actually just carry a sign next to my computer that says, "I will call you on the telephone," or "Can you hear me?" or "I will call you back." And this can actually save a lot of time and a lot of effort. And again, it's nothing fancy. It's a handwritten sign that I keep by my computer to help communicate with the patient. I should note that this version of Epic does have a whiteboard. However, I have to admit there's a little bit there's much to be desired on the whiteboard in terms of functionality. So it's not quite as easy to work with as I would like right now, and I'm sure that will improve in the future. But low-tech solutions like this can still very much work. And on the next slide, I'll remind you that obviously the telephone itself is a good alternative solution. And now you're still able to bill for patients that you're able to do telephone visits with, as Patty and others have said. And then also recall that because of CMS loosening restrictions on HIPAA compliance, we can now use Zoom, Skype, and FaceTime, which were traditionally not thought of as being HIPAA compliant, but in the modern day of COVID, these now are allowed. I wanted to briefly mention one application that I actually liked quite a bit, actually, is the Doximity dialer video. And this is something I just kind of came across incidentally while using the app to call a patient. I actually noticed that they actually had a video function within the app itself. So Doximity is essentially like the LinkedIn for physicians, and it is free for healthcare providers. And they actually have a video application that you can help communicate with your patients, and it's very easy to use. On the next slide. So what you do is actually just once you have the app, within the app they have a telephone interface where you can actually just type in the number of the patient. And the great thing about this is that you can actually use your personal cell phone, because you can customize your ID, your caller ID at the top of the screen there. So you can see that I actually customized the caller ID such that the patient will see the number coming from the Stanford Cancer Center as opposed to my cell phone, which is nice. And so when you call the number, what it does is it actually texts the patient a link to a Doximity app, which actually opens up an application to FaceTime with the patient. And they don't need to download the app ahead of time, and they can actually just use this right away by clicking on the app. And this way, I found you don't need to have a Zoom link provided to the patient. You don't have to have that sent through MyHealth or any other modality. And I find it to be a little bit quicker than any other platforms. In addition, as opposed to FaceTime or Skype, you don't have to give out your personal number, which is also very useful. On the next slide. And the other problem I want to talk about is what we call the zoomed-in face problem, which is a technical term, as you can tell. And this is where when you start with your video visit, you're just kind of talking to the patient's forehead or eyebrows. Not a very effective method of communicating, as we just learned. But if you actually look on the bottom right, there's a small thumbtack icon. And if you click on that icon, you can actually zoom out on the patient and see the patient in full. So this is, again, probably many of you know this by now, but it is a common question that I get when I'm seeing patients with learners or other physicians who have this commonly occurring. It actually kind of funny, yesterday, when I was starting a visit with a patient with prostate cancer, the video was actually zoomed in on the patient's shirt, and it had these big block letters that said WTF. And I thought that was a relatively aggressive t-shirt to wear during his video visit. But when I zoomed out, I saw beneath that WTF stood for "Where's the firewood?" And he was actually an avid camper, so that's why he had it. So it's an important little icon that you can use for your patients. On the next slide, I wanted to address the disappearing video window issue. And the next generation of Epic updates should fix this, if not already this week. However, you'll notice that when you're talking with the patient, you have their video screen up and the video window up. However, if you're trying to look for a lab or a scan or even start typing on the note, the video window disappears and goes into the background. And that can be kind of frustrating, going back and forth and toggling between the different screens. And it's nice to be able to have the patient's window up so you feel like you're actually talking to them if you were to type on your note. So one workaround until the actual update goes live is to actually share your screen with the patient. So if you go into the bottom right, you'll see a icon that says share icon. And if you actually click on that icon, you can choose which screen you want to share on your laptop. And if you actually share the actual video window with the patient, they actually will be minimized, but they can still see you, and then their screen will stay on top. So a little bit of a troubleshooting, quick fix for this until Epic gets around to fixing this problem, though. On the next slide, probably the biggest complaint that we have right now is that we currently don't have multi-party collaboration on MyHealth. However, that is coming in the next iteration. So we will certainly get this. And until we do, I think that it's very important to recognize that, the days of physician and a patient being in one room and having interaction are all gone now. Medicine is very multidisciplinary. So we use our nurse coordinators, our medical assistants, our nurse practitioners, and our scribes. And it's really important that we're able to use these also in Epic today. So on this next screen, I wanted to give a couple methods of working around the multi-platform issue, the multi-party platform issue. So one is actually, as someone mentioned earlier, using two different modalities here, both MyHealth and Zoom at the same time. So we have a physician on the left there. They use a computer to connect to MyHealth to interface with the patient. However, they can also use either their personal device, the laptop, or a cell phone to get on Zoom and send that invite to the scribe or nurse coordinator, who are then listening in on the conversation. And this has still actually been pretty effective. The audio actually worked out pretty well for the most part, and allows people to be in different rooms. I think this is especially useful when everyone, the provider, the scribe, the nurse coordinator, are all at home, for instance, and unable to be in the same location at once. The method I tend to use mainly for interaction with my nurse coordinators and our medical assistants is actually using Jabber, which is something I hadn't used before. It's often something that our medical assistants actually use to communicate to each other about when patients are being roomed or patients that need vitals, for instance. But I actually learned that we all have access as physicians and healthcare providers to Jabber, and everyone on the Stanford Hospital and university side. And it is a HIPAA compliant chat. So it is somewhat like a poor man's AOL instant message, but it does work well to effectively communicate with the team members and let them know when you need certain things done for patients. So I find it to be pretty effective. And then on the last slide, I'll just close by saying that the help desk is there for us. But most importantly, which I didn't realize until recently, is that it's also there for patients too. So patients can also call this number if they're having difficulties with their video chats, and they can actually contact the number, and Stanford will help them and guide them through the process, which I thought is a very helpful tip. So with that, thank you very much for having me, and I hope these are very useful for you.
Wow. So I want to thank all our presenters for doing really a stunning job in a very timely manner. Congratulations, everybody. You presented so much information, and I feel like you collectively told a really great story. We started with Gil, who basically established that telemedicine is not one size fits all. It's really doesn't suit everybody, and there are different modalities. Donna took us into optimizing connection, making meaningful connection, and kind of the best of telemedicine. Pete and Patty, you described so many resources, and I learned so much from looking at your slides, and look forward to digging in more deeply. And I will talk about access to slides in a moment. And then Rika, you articulated the fact that we're all learners, which indeed we are, learners and teachers. And Sumit, you are a great teacher, and you taught me quite a number of things. And I have to say, I'm getting chats privately. Most notably in the last, Sumit, your presentation, I received a number of private chats saying, oh, I didn't know that. Oh, that we should try this. And so there's quite a lot of banter on the back end. I really appreciate all of your contributions and talks. And I want to just on a kind of logistical point, say that the slides will be available on the Teaching and Mentoring Academy site, website. And if you're interested in CME credit, and this has been in the chat, but in case you haven't checked the chat, please email Claire for CME information. And we now have time for questions. And I see a few questions, but I really urge those on chat to pose your questions, because we have this tremendous collection of people together. I'm going to launch with a question. I think this is a question to Patty, but it's really to everybody. And that is, it strikes me that there's so much collected wisdom and experience. And I wonder if you think SHC Connect is kind of the final common pathway for best practices and shared wisdom in our community, and maybe in connection with the help desk, which Sumit mentioned.
Yeah, I mean, I think so. I think the AskSHC website is relatively new, and it kind of reflects trying to merge all of these places we used to go. You used to go to Epic Central, you used to put in service requests for your computer. It was hard to know where to go. And the idea was, let's give everybody one place where they can go. And let's also not have them try to figure out, where does my request fall in this rubric? Let's give them the Google style, my computer doesn't work. I forgot my password. My VidYO app isn't working. Can I access VidYO from my Mac computer? How do I bill for a video visit? Let's just let them type those things and make this work. And so the AskSHC website really is great. I encourage everybody, if any question is burning in your mind, like some of the tips that Sumit showed, there are on the AskSHC website. A lot of those tips are there, like video visit, the patient's face is too big. And it's a really smart, website. So I do think it is a good source of truth to collect a lot of information. It also branches out. Like I think I mentioned that it'll take you to the compliance website if that is relevant to the question that you're asking, or it'll take you to the Office of General Counsel if you're wondering about, can you see an out-of-state patient who's a new patient? And so it kind of centralizes and points you out as needed.
Thank you so much. Does anybody else have additional thoughts about collecting our wisdom and best practices? I feel like Donna, I know that on the chat there was a question about, and you answered, but just for the benefit of those who are not on the chat, if you're planning to study the key principles embedded in the Telepresence 5. And I wonder if that's another way of coalescing best practices and bringing our community together with a kind of shared language and potentially shared practices. I wonder if you have thoughts, or if you'd like to pitch the idea of studying Telepresence 5. You are muted.
Okay, sorry. Our team is very interested in evaluating this for sure. Just for the reasons you mentioned. I mean, right now we've brought together what we think are best practices, but we need to evaluate that and then help disseminate the evidence around it. We have started studying the in-person version of Presence, and actually some of the folks on this call have been our partners with that, but would love to now study the telepresence practices. So to that note, if any clinicians are interested in partnering with us with that work, please let me know either by chat or email. And the other thing we're very excited to do is to bring this to medical students and residents. And I think we've been in touch with Rika and Erica, and now Pri and Tracy as well have chimed in. And so we're hoping to do some work there, bring it to medical students, and then study whether we can, that helps them grow some of their communication practices online.
Thank you so much. I'm seeing that I'm not actually seeing the question. Oh, here, from PM, how can patients prepare to improve the visit? And what can we send them in advance to make the experience better? Donna.
I can just start. I'll put something in the chat about, there are a couple of resources that are out there online, and some places like Mayo have made some pamphlets available to patients. I don't know, someone might be able to speak to whether Stanford has specific materials for patients. A lot of the materials that are available are very much around the logistics of setting up the visit and just technical issues, which are very important, obviously. I think there's room still to create materials for really how to make sure, to help patients make sure that their needs are met in the visits and some of these connection questions. But I'll put some things on chat, some resources.
Rika, I wonder if you have thoughts about leveraging learners in that context, their energy and time.
Oh, that's a good question. I think that I certainly feel like many of my learners are very savvy with being able to lead patients through technology. I remember in one of the exercises, the actor is on mute, and normally they would say use a mute button, but I think the student knew a keyboard shortcut that none of us knew. So I feel like it would be very helpful to leverage their know-how and their skills, and they're also really fantastic in terms of being able to reach out and find out the underlying problem. So I almost feel like in some of the issues that Dr. Chu mentioned, we could leverage their strength in terms of integrating them more into being able to do video visits as well. I know, Erica, you've done some work in that in COVID-19 where students were contacting patients who are elderly and living alone. So in a similar vein, I can imagine that we could leverage their strength in being able to decrease the disparities of telehealth.
Yes, and actually there's definitely buzz on our chat, and I think many of us, well, Dr. Chu and Shai mentioned specifically the disparities. I think many of us are really worried about the patients whom we're not yet reaching, and trying to reach out to vulnerable populations, and to what extent we can leverage technology to do that, or at least help people connect with telemedicine. So I wonder, I know that Christine wrote in the chat that there will be a whole session focused on health disparities in telehealth. Oh no, that was Lars, sorry to misattribute. So there will be a whole session on addressing health disparities in telehealth, and I really look forward to that. I think there's great potential both to do good and to increase the digital divide and not do as well as we could. I wonder if anyone has thoughts for this discussion to amplify opportunities that are available to us now as far as addressing disparities. Don, I can't hear you.
Sorry, I have to unmute myself in two places. I was just going to echo some of what Dr. Chu said, in that it's really important to think broadly about the underlying reasons for some of the disparities, because there are technical issues, language issues, trust issues, and they're going to require nuanced interventions. And so, really understanding the population that you're serving and the various reasons that they might not be choosing telemedicine, and then also being ready to explore the alternatives, as people said today, a phone and things when that's more in their comfort zone is important. So I think there's a lot of work now happening around disparities in telemedicine and documenting it. And the other thing I'll just mention is that in the VA, we've been studying virtual care for a while now, and we're seeing a lot of, patient populations who you'd think might have challenges using technology, patients who are homeless, and, patients who don't have good connectivity, we do find ways to make it work for them. It just takes, very explicit efforts to do so.
Thank you. Thank you so much. We have 3 minutes, and I wonder if any of our panelists has a burning issue they wish they had said while they were talking, or any, let's see, or a question that you answered in chat that you'd like to say out loud. Sorry for the silence. It's kind of hard to moderate, and anyway. I'm going to thank you abundantly. This was really great. The speakers did such a wonderful job. And this is really just the beginning. It's the beginning of this 5-part series. It is at the beginning of the rest of our lives doing this work. And thank you all for really coalescing and starting to create a community that's working together to improve telemedicine and telehealth on behalf of our patients and their caregivers. So thank you so much. You can expect to hear from Christine about future seminars. I think Christine might want to even wrap it up. I saw her Do you want to say anything, Christine? Can't hear you.
Yes, I just wanted to say thanks to everyone, and we will be sending out evaluation, the request to, for evaluation of the seminar, and then we're going to have